Okay with you, Deacon?
Yes.
All right. So good evening, everyone. Thanks for joining us this evening. We are fortunate to have Deacon Rob Lanciotti from St. Elizabeth Ann Seton, who previously worked for 29 years as a virologist for the CDC. He has worked both in vaccine design and development as well as diagnostic test development. While he's a native of other parts of the country, he did his PhD here at CSU and has worked here at CDC since the end of the 80s, I guess.
Exactly. Yes.
So we'll call him a near native. On that happy note, I'll just add he retired from the CDC effective January 1st of 2019. He's been a deacon now for almost 4 years, and as I mentioned, is assigned at St. Elizabeth Ann Seton. We are fortunate to have him. On behalf of the Northern Colorado's Catholic Medical Association Guild, we welcome him. And as we get started, we'll ask him to start us in prayer.
Thank you. Let's, in the name of the Father, and of the Son, and of the Holy Spirit, amen. Heavenly Father, we come before you grateful for all that you've done in our lives. We thank you for the privileged position that we all hold of being able to serve you in our vocation. We ask you to be with us tonight, lead and guide this discussion, help us to acquire the things that we need to acquire to serve you better and to love you more. We pray these things through Christ, our Lord and Savior. Amen. In the name of the Father, Son, and the Holy Spirit. Amen.
So as Deacon gets started, for our participants, there is a Q&A available. So if you have questions as we go through the presentation, please feel free to enter them there, and we will be responding to those during the talk if appropriate. Otherwise, we'll try and save questions for the end of the talk where we can group if there are multiple on a similar topic.
Okay, thank you very much, Monica. It's my privilege to speak to all of you tonight. And, I thought when I retired from CDC that I was finished giving scientific presentations, but it's my privilege and my joy to be able to talk about something near and dear to me for many, many years. Now, before we can speak about these progress that's been made with these COVID vaccines, I'm going to take us back into some kind of fundamentals of virology and immunology, because I think in order to understand these vaccines, we have to understand a little bit about viruses and how they replicate, how the immune response takes place. And then I'll talk about the vaccines themselves, not all of them, of course. I think you may have heard there's almost 200 vaccines in some type of development, but I'm going to talk about the top 3 that are closest to getting some kind of emergency use authorization in the United States. And then I'm going to conclude with the ethical concerns, and this is kind of a hot topic right now, the ethical concerns associated with these COVID vaccines, and I'll talk about what the Catholic Church has to say about the use of these vaccines. So please bear with me in this early part. This is going to look a lot like a microbiology, virology lecture. And if I lose anyone, please forgive me. And I think if there's a burning question, we could probably stop and I could cover it, in this point, so we don't lose anyone. And some of you, this may be information that you're fully aware of, so forgive me if I'm going over things you already know. But one of the critical things to understand about viruses is that they are intracellular parasites. And the easiest way to understand that is, if you had a flask of some very rich broth and you inoculate bacteria in that, in a few hours, you're going to be overgrown with bacteria. Bacteria possess all of the cellular machinery needed to replicate themselves. If you conducted that same exercise and inoculated a flask of rich medium with a virus, absolutely nothing would happen. Viruses cannot grow independently. They require living cells to get into, and they actually utilize all of the cellular machinery. They have no way of making their own protein. They use ribosomes from cells and so forth. So they're intracellular parasites requiring cells to grow. Viruses themselves there's a huge number of them, and they range in size from very, very small up to about 500 nanometers. The pox viruses are very large. They're basically particles consisting of nucleic acid and protein. Most are surrounded by a bilayer lipid membrane. In fact, the same membrane that it's stolen. It's a stolen membrane from the cell they infected. So this little picture here, I'm going to see if I can get my laser working. Pointer options, laser. There we go. This would be a typical small scale virus. This is the genome, and viruses come in all flavors. There's RNA viruses, there's DNA viruses, single-stranded RNA, double-stranded RNA, and so forth and so on. The nucleic acid is typically surrounded by some kind of protein to protect it. In many viruses, it's called a capsid protein. But the key is this protein that's found on the surface of the virus. In the case of corona, it's called the spike protein. In other viruses, it's called the envelope glycoprotein. But the important feature is that this protein found on the surface of the virus is what is responsible for allowing the virus or allowing the virus to gain access into a potential host cell. And what a virus does is, this is some electron micrographs of coronaviruses. And coronaviruses, as you may know, they get their name from that spike protein that surrounds the virus that looks like a crown, because corona in Latin stands for crown. So this is how a virus cycles through and replicates. And so starting at the top, we've got our virus particle with a spike protein on its surface. And this is an important feature in terms of immunology and how we can protect cells from getting infected. The spike protein will bind to a protein that's found on the surface of a normal host cell. And viruses have adapted multiple ways to appear as if there's something the cell wants. So in many cases, these cellular proteins on the surface are receptors, or hormone receptors, or cytokine receptors, sialic acid containing proteins. So basically the cell thinks that it's encountering something that it wants to ingest. And so virus will bind to the surface of a host cell. The cell incorporates it. It then disassembles. So the viral particle disassociates. Sometimes it's called uncoating. And this naked nucleic acid is then released. Now, again, this depends on if it's a DNA virus or an RNA virus. In the case of corona is what is called a plus sense RNA virus. Plus sense means message sense. What that means is that RNA molecule is directly able to be translated by cellular ribosomes. So this virus will uncoat. The nucleic acid can do a couple of things. First, it can be translated into more viral proteins. The nucleic acid itself can be replicated and copied. All of this is accomplished using normal cellular proteins. And so this is what I meant when I said a virus is an intracellular parasite. It literally uses all of our normal cellular machinery to replicate itself. At the end of the process, there's multiple copies of the genome. Let's say if this is corona, this would be multiple copies of RNA, multiple copies of the capsid protein that surrounds the RNA. All of these proteins, nucleic acid, they all come together at a certain point, and they go through a process we call budding, which means the capsid protein, and the reason I'm dwelling on this is important for immunology as well. The protein that is found on the surface of the virus particle that was up here, this capsid protein, is now inserted into the plasma membrane of the infected cell. And the viral particle, the nucleic acid, buds, it pushes its way out. It steals the lipid bilayer portion of the membrane. And so we have a new virus particle. But this is important, that the surface of infected cells is covered with viral protein. Okay, that's an important component of stimulating the immune response. Some features of viral infection: it's exponential growth. In this little diagram, it looks like one virus is coming in and one's going out. In reality, one may come in and hundreds or thousands may go out. Replication, interestingly, can have almost no effect on the cell. Some viruses have adapted such that there's no adverse effect on the cell, or alternatively, there can be cell lysis and death. And so disease in a viral infection, and this is very broadly speaking, but in most cases, disease is either the direct result of cellular lysis. The cells themselves are dying as a direct result of viral infection, or indirect. So sometimes there's an inflammatory response against infected cells, and that can result in the disease that's observed. This is one of the things they're looking at with coronavirus infection, the so-called cytokine storm. That's actually a response to infected cells. Okay, so I hope that's clear as mud, but we can now talk about the immune response to viral infection. And basically, the hallmark of the immune response is this twofold response. There's what's called the antibody response, and then there's the cellular response, or the humoral response and the cellular response. And basically, that means that antibody molecules are produced by B cells in response to viral infection. So, and this is a much more complicated process than I'm making it out to be, but all we need to know is that when you're infected with a virus, and when a cell is infected, again, the surface of that cell is coated with viral proteins that stimulates T cells, and those T cells, known as T helper cells, both stimulate the production of B cells, which are antibody producing cells, as well as what are called CD8 T cells, or killer cells. So what's happening in the immune response, in a very simplistic way of saying, is that you make antibodies which can neutralize virus. And this is the important feature here. So these little drawn sticks here, these are antibody molecules, and they bind to the surface of the virus. And if you can imagine the entire surface of that virus covered with antibody molecules, that viral particle can no longer enter into cells, because this spike protein, in the case of coronavirus, requires direct interaction with a cellular surface protein. If you have an antibody molecule stuck to that viral protein here, it prohibits the interaction, and so virus can no longer enter cells. We call this reaction virus neutralization. These antibodies, in turn, are known as neutralizing antibodies. So this is essentially one half of the immune response to viral infection. The other feature of B cell production is these are cells that are activated, they're clonally expanded, and they produce antibodies for life. They're activated for life, and so you can measure the existence of these antibodies for a long time. And I'll talk later about antibodies waning with time. I mean, this is something that we know happens with many viral infections. You can measure the existence of these antibodies in a number of tests. And so for coronavirus, for example, there is an antibody test available, as well as for other virus infections as well. So antibodies are detectable, and their concentration changes with time. However, their presence is still there many years later and able to neutralize the virus. T cell activation, again, is these CD8 killer cells. These are cells that specifically recognize infected cells because there's viral protein on their surface, and they lyse those cells. And they're also clonally expanded, they activate, and they're activated for life. So that's essentially the immune response. All right, vaccination. So the whole key of vaccination is you want to activate the immune system in a way that's similar or identical to a natural virus infection. You want to produce neutralizing antibodies, and you want to activate the cellular response as well. That's the whole point of vaccination, such that subsequent exposure to virus leads to rapid clearance and no disease. And the important point is no disease. You don't really achieve sterile immunity. You know, if someone is exposed a year later to a virus they've already been infected with and developed an immune response to, with a very sensitive test like PCR, you probably could detect the presence of that virus. But nonetheless, the existence of those antibody molecules and activated T cells will lead to rapid clearance and no disease. That's, of course, if everything works according to plan. So that's what vaccination is all about. Vaccines are approved by the FDA, as you all know, and potential vaccines go through these phases 1, 2, and 3 of clinical trials. What they're looking for at the FDA, again, obviously, is vaccine efficacy. Does this vaccine actually produce immunity? Does it make neutralizing antibodies? Does it activate T cells? But most importantly, does the vaccine protect from symptomatic disease? And I'll talk about how that's through phase 1 through 3, how that's done. And of course, vaccine safety is the other feature. We want safety. They want to see the frequency of adverse reactions to the vaccine and whether or not they're mild or severe. So this is what happens in FDA clinical trials. You really cannot determine duration of immunity because even in the standard, we're right now at Project Warp Speed, where we've developed coronavirus vaccines in record time. But even under normal circumstances, the process may only take 2 or 3 years. That still doesn't tell you much about duration of immunity. That's something that has to be done down the road in follow-up studies. So for example, when I was at CDC, we were looking at the yellow fever antibody titers over time, 20, 30 years from vaccinations. That's the only way you can determine those sorts of things. So basically, FDA phase 1 is a very simple kind of trial. You vaccinate usually less than 50 people, and you do in vitro experiments looking for the existence of neutralizing antibodies in their serum, and you do experiments looking for activated T cells. So if that works, if the vaccine looks like it's producing antibody and activating the T cells, then you move on to phase 2, which in general is just an increase in numbers and also some stratification of various age groups. You include more people in different age groups and so forth. Phase 3 is where the numbers usually go 30 to 50,000 people. And in phase 3, you essentially conduct an experiment in nature. So believe it or not, there was a time in vaccine history when you could actually experiment on humans. And so you could vaccinate someone and then you could challenge them with virus. So of course, obviously we don't do that anymore. But what we do, and what's being done with COVID right now, is you vaccinate a certain number of people and you give the other part of this population a placebo. And then you just let them live out in areas where there's active virus transmission going on. And you keep, in addition to looking for in vitro assays of do they have neutralizing antibody and are they experiencing any adverse events, those are the same things you look at in phase 1. In addition, in phase 3, you look at are people protected? And if people come down with COVID, you then, when you're at the conclusion, you can find out whether they received the vaccine or the placebo. So phase 3 is really the important portion of these studies where you find out what you're really looking for, which is are people protected from disease? And I'll talk about what we know so far when I get to the specific vaccines. Vaccine safety is monitored by this VAERS, which is Vaccine Adverse Event Reporting System. In their terminology, you can categorize adverse events in terms of mild, severe, and serious. Mild is something that most people will have, some pain at the injection site, perhaps low-grade fever, headache, and so forth. Severe is something that requires medical intervention, but it's not life-threatening. Things like seizures, anaphylaxis, even high-grade fever, serious hospitalization, long-term disability, encephalitis, death, things like Guillain-Barré syndrome, and in some cases, people die from the actual disease that you were vaccinating against. So, example is vaccine-associated poliomyelitis, and that actually there's a long history of that. There was a period in history where a batch of the polio vaccine was actually not inactivated sufficiently, and some people actually got polio from the vaccine, some paralysis, and some passed away. Yellow fever virus I worked with for many years, we don't know exactly, but we suspect immunocompromised individuals. In the case of yellow fever, at a rate of about 1 per million doses, some people actually develop full-blown viscerotropic yellow fever and die. And again, that obviously is something that occurs at very low frequency, but it's a serious adverse event. So all these things are recorded in the VAERS system. Allergic reactions are based upon things that you find in these vaccines. They contain thimerosal, which is a preservative, aluminum salts as adjuvants. These are things that are added to increase the immunogenicity of the vaccine. They most times promote slow release of the antigen so that the immune system is very stimulated. They're stabilizers. In the case of flu, there's some egg protein because the virus is grown on embryonic chick cells. If it's a killed virus, it's usually killed with formaldehyde, so there could be traces of that, as well as traces of antibiotics. So it's not a surprise that there would be some low frequency of adverse events to vaccines. In some cases, actually in most cases, establishing a direct link between vaccination and the adverse event is difficult. It's clear when you have something like yellow fever, someone actually acquires yellow fever because you gave them the vaccine. However, some of these allergic reactions, depending on the time they occurred from vaccination, it's difficult to prove whether or not the vaccine caused it or whether it's just coincidental. This is an example of serious or severe adverse events on the vaccines that we currently have. I'm not going to go through all of these, but the take-home message is that in general, there are somewhere between 1 and 2 of these adverse events per million doses given. And you can see here some of the ones I mentioned: vaccine-associated paralytic poliomyelitis, yellow fever, allergic reactions, and so forth. So again, the take-home message is very low frequency. However, when one contemplates the idea of vaccinating this country against coronavirus, we have 350 million people, I think. So unless these vaccines are exceptionally better than everything we've developed thus far, we will see adverse events, some very serious. I mean, there's no such thing as a perfectly safe vaccine. At some very low frequency, they all cause adverse events and even death. So I just say this because I think the way things are today, the first adverse event to any coronavirus vaccine will be on the I would say front page, but we don't have front page. We have internet now. Everybody in the world will know about it. It'll probably frighten people, unfortunately. And of course, it's a tragic event, but however, it's expected. It's not something that's unexpected. I'd be surprised if the frequency of adverse events were significantly different than the vaccines we've been using. I think the 2 leading candidates we have for coronavirus, they should be inherently a little more safe, but I'll talk about that when I get to those. All right, so the types of vaccines that are in current use and production. So this is a traditional, the first 2 methods I'm going to talk about are what I would call traditional ways of making a vaccine. They're conceptually very straightforward. So the easiest thing to understand conceptually is you take a virus like polio, you grow it on cells, you produce large amounts of it, and then you just chemically kill it and activate it by formaldehyde or beta-propylactone. And then you inoculate that, and the recipient, the vaccinee, the immune system responds as if it were infected with live polio. Now, because the virus is not able to replicate, and again, these chemicals target nucleic acid. So basically, you chew up the nucleic acid part of the virus, and you leave intact the particle itself so that the proteins act as immunogens and stimulate the immune system. So it works well. However, and it's moderately rapid, because all you really need to do is grow up the virus and mass produce it. It doesn't require a lot of lengthy research and figuring out how to attenuate or something like that. So it's fairly fast. On the downside, these are generally show a lower efficacy. They require multiple doses. In fact, I think the killed polio vaccine we're now using requires 4 doses. That's because it's just a dead particle, and you have to stimulate the immune system. And almost mimic replication in the way it's given. There can be allergic reactions to chemical components and so forth. This is the way influenza is made also. And if you think about flu, they're studying what's happening in the opposite hemisphere during part of the year, and they're able to produce this inactivated flu vaccine in about 3 or 4 months and have it out. So it's a fairly rapid approach and fairly straightforward. Attenuated vaccines you basically take the virus and you do certain things to it such that it replicates, but it's no longer causing disease. Now that process can take a long time. So for yellow fever, for example, you take live yellow fever that is able to kill people, and you start passing it in cells that it doesn't like to be in, dog kidney cells or hamster cells or whatever. And you're basically genetically selecting for a strain that at some point appears that still replicates in human cells, but it no longer causes disease. And that's how an attenuated vaccine is made. As you can imagine, that process can take a while. There's a lot of research and development, selecting clones of virus, analyzing them, and so forth. So it does take a long time to make an attenuated vaccine. Oral polio, which no longer is in use, that was how that one was developed, as well as I think all of MMR. I think measles, mumps, and rubella are all attenuated. And once you've attenuated the vaccine, you get a very robust immune response, because the immune system is seeing live viral replication and it responds that way. So the downside is, in some immunocompromised individuals at some very low frequency, you will get the real disease. You'll have things like polio in some cases, which is why they discontinued the live attenuated polio vaccine. So those are the 2 traditional ways to produce a vaccine, and the only ways that vaccines have been produced for a long, long time. Now, there have been other approaches that have been looked at going back, that I can think, at least 20 years, never really amounted to much, because there really never was the opportunity to put these things to trial. And so with coronavirus, we're seeing for the first time a new concept called RNA vaccines, or messenger RNA vaccines. And this is, again, if you remember what I spoke about at the very early part of this presentation, about how a virus gets into a host cell, it releases or uncoats its nucleic acid. That nucleic acid, if it's plus sense or message sense, can be directly translated into protein. That's exactly what Moderna and Pfizer have done. They have taken, they have made a synthetically produced a messenger RNA that codes for just one of the COVID viral proteins, which is the spike protein, which, by the way, every coronavirus vaccine uses this spike protein as an immunogen, because that is the protein that elicits neutralizing antibodies, because antibodies to the spike protein bind to the viral particle, preventing it from entering potential host cells. So the RNA vaccines, synthetic RNA that codes for that spike protein. Now, RNA normally is very, very unstable, that if you just injected RNA into someone, it would be degraded very quickly, and very little of it would get into cells. So they have developed this lipid nanoparticle technology. Basically, they're creating their own little viral particle, RNA surrounded by or encapsulated in a lipid nanoparticle. And because it's lipid, it literally can slip through the lipid bilayer membrane of cells. And so it can sneak its way into cells. What happens then is that RNA gets translated by the cellular ribosomes, and the spike protein then gets taken and expressed on the surface of those cells, stimulating the immune response, both the cellular and antibody response. So this is actually a brilliant way to do a vaccine. It's very rapid. In fact, Moderna, all you really need is the nucleic acid sequence of the virus to make this. Moderna had a vaccine, I think they got the sequence somewhere around January the 12th, and they were vaccinating people by March. It's phenomenal in their phase 1 study. So it's rapid because all you have to do is have the nucleic acid sequence. You can design your messenger RNA and then produce this RNA synthetically. Theoretically, it has fewer contaminants, or theoretically, it should be safer because it has fewer contaminants. There shouldn't be any formalin or antibiotics and so forth. RNA is also very safe. There were DNA vaccines that were looked at, and I think they're very safe as well. But DNA could potentially integrate, since it's a double-stranded DNA, it could integrate into host cell chromosomes, creating problems. So RNA doesn't have that. I mean, some people have asked that question. RNA does not integrate because RNA does not integrate into double-stranded DNA. RNA is actually rapidly degraded. So what it does is the RNA gets in, it does its job, and then it's degraded by the cell as if it were never there. And then you've got the immune response stimulated. I have down here as on the minus side, it's an untested approach. We don't know about the duration of immunity, but I think only time will tell. So this is just some data from their phase 1 study. I combined both Moderna and Pfizer. They're Moderna and Pfizer. I don't even know how they can get patents. They're basically identical. So maybe some slight differences in how they package and so forth and so on. But they're both messenger RNA molecules coding for the spike protein of coronavirus. So they inoculate some volunteers. They collect serum at certain time points. They test the serum looking for antibody. That's what the ELISA test does. Then they do what's called the plaque reduction neutralization test, which measures neutralizing antibodies. So not only do you detect total antibody, but you detect the subset that are neutralizing. And there's also in vitro assays to look for the T cell response. They also took convalescent serum from patients that were naturally infected and used that as a comparator. Of course, people found pain at the injection site. Some of these minor reactions to vaccination. There were no serious adverse events. They detected neutralizing antibody in all the vaccinees at levels greater than convalescent sera. That's pretty interesting. So according to that phase 1 study, people were making more antibody than in natural infections. And then T cells were activated. And then at the bottom here, there's this one difference. Moderna has to be frozen just in a regular freezer at -20. But for whatever reason, I don't understand, Pfizer, their vaccine has to be stored at -80 or in ultra low freezers, which creates some logistical difficulties. Now, jump forward to phase 3, both Moderna and Pfizer. If you remember, in phase 3, they're actually looking at protection. So not only do these people develop antibody, neutralizing antibody and activated T cells, but interestingly, they followed these people. I don't remember, I think it was Moderna, somewhere around 200 people came down with symptomatic coronavirus infection. And so when they broke the code, they found that 95% of those people were in the placebo group. So in other words, the vaccine protected 95% of the people from getting any kind of symptomatic disease. And even more interesting is among those symptomatic cases, and I think there were about 20 or 30, there were a few severe coronavirus infections. None of those occurred among vaccinees. So this was released a couple weeks ago, maybe a month ago now. Very, very encouraging data that these RNA vaccines, both of them, And I don't know if 90 to 95%, probably when this gets into millions of people, it may be that these are numbers end up being the same rather than, I don't think that one's better than the other. I think they're both showing to be very good vaccines. But these vaccines apparently in the study of, I think, 30 to 40,000 people are protecting against severe coronavirus disease in all cases and protecting 95% of the time against any symptoms at all. Okay, so the other approach that's being taken and the other leading candidate is the adenovirus chimeric vector vaccines. And this requires a tiny bit of explanation. So this is another approach that's been looked at for making vaccines. And that is, you take a virus that causes little or no disease and you swap out a gene. You take something out of it and you put into it the protein that you want antibodies to be made against. So in this case, they've taken out a part of the adenovirus genome and they've inserted, once again, the coronavirus spike protein gene. And so what happens is this adenovirus, which causes no disease in humans, I think AstraZeneca is using a monkey adenovirus, but the Chinese are, there's so many different serotypes of adenoviruses that don't cause human disease. And so different people are picking different adenoviruses as their vector, and they're creating a chimeric virus that has adenovirus, mostly adenovirus, and has the coronavirus spike protein gene inserted. So what happens is infection occurs and this capsid or the spike protein of coronavirus is translated, expressed on the surface of cells. It looks like a natural virus infection, and antibodies and T cells are activated, and there's an immune response. This is a different approach in the sense that you have to grow this chimeric adenovirus to make the vaccine. And so as a point to put in the back of your mind, this recombinant virus, whether it's AstraZeneca or the Chinese have one, I think it's called Sinovac, but whatever it is, whatever company it is, these chimeric adenoviruses are grown in HEK293 cells, which stands for human embryonic kidney, which traces itself directly back to an aborted fetus. So the thing to remember is any vaccine that is grown, that is a virus or a chimeric virus or a killed virus, you have to grow that virus in order to produce the vaccine. And in many cases, they're grown in cells that have their origins in aborted children. So right now, AstraZeneca, which was at one point, I think, in front of everybody, they've had some production problems. They've also had some errors in their phase 3 clinical trial. So they're now back to number 3. And the two leading candidates in the United States are both RNA vaccines. But their data does look good. They actually combined phase 1 and 2 to speed up the process. They looked at 500 volunteers, very similar kind of experiment, gave them 2 doses, which, by the way, I didn't say. All of these, the RNA viruses as well, require 2 doses. And in the AstraZeneca phase 1 and 2 trial, they used as a comparator meningococcal vaccine. They just wanted to see, they wanted to sort of wash out and look at adverse events, whether it was specific to the chimeric adenovirus vaccine or whether it was just a generic response to vaccination. They collected serum at certain time points. Again, no serious adverse events. Actually, there was one, but it was among a meningococcal vaccinee, wasn't among the COVID vaccine. They detected neutralizing antibodies in all their vaccinees at levels similar to convalescent sera. So people are making antibody just like if they were infected, and also activated T cells directed towards the spike protein. So the data actually looks pretty good, but they're having problems, and I don't know how far behind they're going to be. Okay. Now we get into the ethical issues, and I've already touched on these. Use of cells derived from procured abortions, and that is the crux of the ethical questions. And so, our cells derived from aborted children used in vaccine production. So as I've already mentioned, if you're producing a vaccine that is an attenuated virus, or it's a killed virus, or whether it's a chimeric adenovirus or whatever, it requires growth in living cells. Now, it's a long and sad story, but for whatever reason, historically, most of these human vaccines were grown in cells that were procured or derived from procured abortions. Again, it's a long and it wasn't really, I think, an intentional decision. It was a sample or a material of convenience at the time. For example, the first one was at the Wistar Institute in Philadelphia. And my recollection is there was a procured abortion because of concerns of congenital rubella. And so the researcher thought, well, since this virus was already growing in these fetal cells, these cells are probably a good substrate to continue the virus growing in. And unfortunately, this WI38 cell line became the gold standard for production of the rubella vaccine. And this just led to a series of other cell lines, MRC5, PRC6, and then the HEK293 cells that we're familiar with. All of those come from cells that originated from an abortion. And for unfortunate reasons, these are considered by virologists and vaccinologists to be the gold standard for vaccine production. So the MMR or the MMR V or even the poliovacs are all made in these cell lines that I have listed up here. I don't know exactly which one is with which. So there was a statement issued, as you can see at the bottom of the slide, by a number of organizations pleading with researchers to switch. And there's really no reason why they couldn't. It's just the way it's always been done, and nobody wants to make a change. There certainly are human cell lines that could be used to produce vaccines that don't come from abortions. And it's just a matter of some groups making that change. I mean, these cell lines, as I mentioned, that come from abortions have been all commercialized. And so when it's time to produce or grow something, you can just buy these. And so there just needs to be a change. There needs to be a change in attitude. And there's no scientific reason why we couldn't switch out of these cells. But the fact remains, that's how vaccines have been made, and some of the coronavirus vaccines are being made in these cell lines as well, and I'll talk about that. But back to how we as Catholics understand the evil associated with certain actions. And in Catholic moral teaching, there's this concept of cooperation with evil. And the big division is between what's called formal cooperation and material cooperation. So the way this, I'll just give you kind of a scenario to, let's see, so that I don't confuse everyone involved with this. So the formal cooperation means you shared in the intent. You actually were a co-conspirator in the evil action that took place. Material cooperation is when you provide some kind of support without the intent. So an example of formal cooperation is someone comes to you for advice about an abortion. You actually encourage them to have the abortion. You're a formal cooperator in that evil act. You're advising them, you're helping them make the decision. So you're an active participant. Material cooperation would be something like you drove that person to the abortion clinic. Whether or not you intended for them to have an abortion is another story. And you get further removed because material cooperation can be either direct or indirect. It can be proximate to the event, or it can be remote. It can be something that happens years later, or it can be active or passive. Perhaps passive meaning you didn't protest or you didn't show opposition to it. So this is all from the Pontifical Academy for Life, and maybe some of you have already read this, but it just helps us understand and gauge the level of cooperation that we participate with evil and our corresponding guilt. So what they've summarized in that document, what they've said is that receiving a vaccine produced in cells derived from an abortion is considered material cooperation. So it's not formal cooperation. Obviously, no one receiving a vaccine from these aborted cells, no one planned that abortion with the person. We didn't intend it. We didn't desire it. We had no part in it whatsoever. It occurred 50 or 60 years ago. So it's only material cooperation. Not only that, it's passive, remote, and indirect. And I'm not going to go into all the reasons why but it's the furthest removed type of material cooperation, because it's something that occurred so many years ago. A person receiving a vaccine has no intention of supporting abortion. And so but it is still a type of material cooperation. So what the Pontifical Academy says we should do as Catholics is this: if there are options, if we have options, then we should produce a vaccine that is produced morally. Now, putting aside COVID, up to this point, we've had no options that I'm aware of, because, for example, polio and MMR, especially the rubella component, there are no options. But moving forward, there are some options for COVID. So anyway, the Pontifical Academy says if you have options, you should choose the vaccine produced morally. The National Catholic Center for Bioethics, as well as several others, are telling us, and I agree with them, that the RNA vaccines are morally acceptable. And the reason for that is they're not produced in any cells at all. They're actually a synthetic product. And there are some other vaccines coming down the line that are also synthetically produced. The absence of cells in the minds of the bioethicists at National Catholic Center say that they're morally acceptable because they don't use aborted cells in the production of the vaccine. On the other hand, adenovirus vector vaccines or any of the live or killed vaccines, they're using cells to grow those viruses to produce the vaccine from cells derived from abortions. And so the AstraZeneca, the CanSino, which is a Chinese, I believe that's a killed vaccine. Johnson & Johnson also has, I have a slide at the end, but I think it's a killed vaccine as well. So those are, so if we have a choice based on what the Pontifical Academy has said, we should choose the ethically produced vaccine, which is the RNA vaccines, which, as it turns out, are the only two that are closest to being approved by the FDA. On the other hand, and this would help us if we're dealing with concerns about vaccines that are already some of the childhood vaccines. If the only option that's available is a vaccine produced using those cells, for example, MMR and polio, this is what the Pontifical Academy says we should do. We should express our opposition in writing or by other means. We should abstain from taking the vaccine as long as it doesn't create a health risk for other people. And where there is a health risk, and in fact, the document goes on to talk about there certainly is for things like rubella and polio, the moral obligation when there's a health risk is that moral obligation outweighs what they consider to be a passive, remote, indirect material cooperation, that it's because it's a distant from the evil action itself. When there's a health risk, we have a moral obligation to protect ourselves and to protect others. Okay, so that's what the Catholic Church teaches about vaccines. So in practical terms, that means that if you're dealing with people who have concerns about MMR or polio, we can point them to this Pontifical Academy document. However, moving forward, I think it's important to talk about the options that we have for coronavirus. Now, I thought I had something in here. No, I guess I don't have it, but there still actually is some, oh no, here it's the very last one. Okay, this is just a quick look at all of the phase 3 coronavirus vaccines. And I've added my own notation over here on the left-hand side about what cells, if any, are used to produce these vaccines. So these are the two RNA vaccines. Pfizer is up for emergency use authorization, FDA approval, I think December 12th. So this vaccine, if it's approved, will be administered within weeks. Moderna is a few days behind. I think December 20th or something, they have a meeting with FDA. So these two have meetings scheduled already with FDA for EUA approval. This is the Chinese this is a recombinant adenovirus. So anyway, these RNA vaccines do not use any cells, so it doesn't even apply. This recombinant adenovirus vaccine, as with all of them, uses cells derived from abortion. The AstraZeneca as well. These are two very similar vaccines. They're both adenovirus vectors. This vaccine from Sinovac, interestingly, uses Vero cells, which are monkey kidney cells. So this one would be, if it ever became available in the United States, would be ethically okay. And just jump down here because some of these we'll never see. This is from India. Johnson & Johnson, that's a cell line derived from an abortion. And this down here, this Novavax, some of you may have heard of this. This is, instead of RNA, I didn't talk about this approach, but basically instead of injecting RNA, you're actually injecting the spike protein itself. It's a protein that's protected in some way, and you're injecting that into people, stimulating the immune response. Of course, since it's a protein, it's also produced somewhat synthetically, and there's no cells involved. So that would also be an ethical choice. Now, my last slide. Having said all that, as a summary, the RNA vaccines are not produced from cells that are derived from abortions. In fact, they're not produced using any cells. And any kind of protein subunit vaccine as well are not grown in any cells. However, there is still controversy, and I became aware of this just in the past week or so. There's still controversy, and it is based upon the distinction between vaccine production and research prior to production. So in a nutshell, there was a bishop in the United States who has come out and said that the RNA vaccines from Moderna and Pfizer are ethically unacceptable because they have an association with fetal cells, cells obtained from an abortion. So the distinction, and this may seem subtle, but it's important. It all comes down to what is the moral standard that you're applying here. Are you concerned about vaccine production strictly? And if that's the case, then RNA vaccines are produced ethically because there are no cells used to produce those vaccines. However, the research that went into the knowledge base necessary to produce that vaccine. So for example, just the knowledge that the spike protein is the target that is needed in all these vaccines. All of that research, in some cases, involved the use of cells obtained from an abortion. So if your standard of moral, let's say, purity of a vaccine is that I don't want this vaccine to ever have any association with the use of cells that come from an abortion. If that becomes the standard, then all of these vaccines are equally contaminated, so to speak, morally contaminated, because the research that went into the knowledge that's needed to even produce these vaccines, regardless of what kind they are, some of these researchers somewhere along the way likely used HEK293 cells or one of the other derivatives. And that's what this particular bishop is saying. He's saying maybe it's produced cleanly without any of those cells. However, there's this in the pedigree of its development. Some of that research involved those cells, therefore it's also unethical. Now, in a certain sense, that's sort of a moot point because if that's the case, then all the vaccines are equally in that category of being unethical. And then in that case, the Vatican document would say, well, we have no choice. And so all of the vaccines can be taken because there are no other options available. So this, anyway, you can see this gets into a big controversy that's occurring right now among different people in the Catholic Church about whether. So again, it comes down to the standard of your moral standards. Are you concerned about production, or are you concerned about the entire history of that vaccine's research and design and development, and so forth? And again, killed vaccines, attenuated vaccines, anything that involves a virus, whether it's a genetically engineered chimeric vector virus, or whether it's the normal virus that's later killed. Anything grown in cells, in most cases, the cells were derived from aborted fetal tissue. And so clearly those are in the unethical category. So I think I've spoken long enough. And at this point, I'd be happy to take any questions.
So looking at our chat here, there is a question regarding the data of the coronavirus studies. Was there any demographic information for the vaccinees?
Say again, I'm sorry.
So it's a
Was there any
question
what?
regarding whether we have any demographic information on the participants in the coronavirus studies.
I don't have it, but it's in the phase 1 study. There was a little bit. Yeah, it's out there. The phase 3 studies are probably not going to be published in peer-reviewed journals for a little bit because they're just finishing them now. But what they're submitting to FDA, what they're saying to FDA is yes, they have a really good representation, both racially, age stratified, and there are people a lot smarter than me that figure out, they know how many people of each category they want. And yes, that's all part of the phase 3 study.
Okay. And question, and I apologize, I just wasn't clear. When you said that we have the 200 vaccines in development, and we're looking at the top because everybody's racing for that, but there's reports from other countries about already putting some vaccines out there.
Yes.
Are these different or from other companies besides the ones we're looking at that, or are they having other arms in those countries doing the same thing?
So the Russians have done this. The Russians, they got to about what we would call phase 2, and then they directly went into people. And I don't know if it's on that table, or I don't think it's included on that table, because they actually didn't go to phase 3. They just went right into people. And I believe the Chinese have done that as well, but I think they did more before it went into people. So we don't know much about what's happening. And I think we may not know. I mean, they may not tell us.
So these are not our big pharma companies. These
No,
are
it's their own. So in Russia, it's a group that I used to actually work. I think it's called the Gamaleya Institute. So that each country is making their, like India's got their own Indian Medicine Institute that's making their vaccine. Russia's making their own. China has a couple of their own government pharma companies working. But the ones in this country, it's interesting. I don't really know how this was all decided, but at some point our government invested a ton of money in Moderna, Pfizer, and AstraZeneca. So pretty early on, somebody thought those were going to be the 3 leading candidates, and maybe the money stimulated them to be leaders, but that's why in this country, those are the 3 that will be looked at by FDA first. They're the furthest along in this country, but there is many in preclinical stages, and I mean, most of those will not amount to anything. They just can't compete.
So we've got a few more questions here in the chat room. They vary tremendously. So I'm going to, so one participant said they thought that Pfizer had turned down government money or, funding for their vaccine. Are you aware of any of that?
I think that's right. I think Pfizer, because they're such a big company, they decided they would just do this, and eat the cost on their own. I think that's true. Yeah. Moderna for sure took Operation Warp Speed money because they're a small company. But yeah, I think that's correct.
And so some questions more looking at the development and morality issues. There's a question regarding why we don't have research cell lines right now from umbilical cord or stem cells or adult stem cells. Also a question about what is the effect of the mRNA? Can it become part of our gene pool? Do we have to look at future effects on fetal development in that instance?
Mhm. So two different questions. So the first, let me do the second one first. So, and I sort of addressed this, RNA vaccines, the advantage they have over DNA vaccines is that RNA cannot be integrated into our genome. The way integration works, it's a molecular reaction where double-stranded DNA gets inserted into double-stranded DNA. And so DNA vaccines potentially, and I still think even that's a pretty rare event, but double-stranded DNA vaccines could potentially integrate into our host, into our genomes. RNA, it's impossible. That reaction doesn't exist. And single-stranded RNA is degraded pretty rapidly. In fact, when I heard about this approach to making a vaccine, my first thought was it'll never work. You know, the RNA will get degraded before it ever, you know, gets into a cell, but they figured out a way to keep the RNA preserved just long enough to get into the cell and generate proteins. So no, I don't think there's a concern about any genetic issues of nucleic acid getting incorporated into our genome because it's a molecular reaction that has never occurred, RNA getting into DNA. So the other question was, what was the first part? It was about.
So it was about the research lines.
Oh yeah, why aren't we using? There's no reason we should be using. There are plenty of cell lines available from non-human primates. There's a lot of. So when I was in the lab, I used Vero cells for everything. They're from monkeys. They're great cells. They're clean. Again, the problem is that for unfortunate reasons, the gold standard in the field became, the gold standard in vaccine production became the use of WI38 cells, MRC5s, HEKs. There's reasons for how that happened, but that's just the fact of life. And so when a virologist says, I'm going to make a vaccine, the first thing they do is they look into what is the cell line that this virus has previously been grown in. And they see those cell lines and they make a purchase with a company because these things are commercially available and they just go about their business. So it's just a pattern that needs to be changed. There's no scientific reason why we couldn't switch to other cells.
So we've got a lot of questions now, and rather than try to sort them at the moment, I'm going to start at the top here.
Okay.
One was a question about possible nasal delivery, only the IM, and whether that would provide an increase in efficacy.
It hasn't been looked at in the leading candidates, so I don't know whether it would be better or worse. For whatever reason, they all chose IM as their their way of vaccinating. I'm sure in that list of 200 potential candidates, somebody's looking at that, but none of those are in the. I don't see any reason why they wouldn't look at that, but they're not. They're not.
From one of our PharmDs, the question again about the mRNA becoming part of our mRNA. So does it continually produce that spike protein, and for how long?
No, again, it's degraded. And this happens even in typical natural viral infections, is that our cells are inundated with viral RNA and then it's just all gone after. You know, RNA is very rapidly, it's a single-stranded nucleic acid, very labile, and we have enzymes in our cells that chew up and degrade single-stranded RNA pretty rapidly. In fact, you get into the weeds here. Moderna, you know, there's the 4 nucleotides, A, T, C, and G. They actually use a modified nucleotide in their vaccine to slow down that degradation process, because if you didn't do that, the RNA would be degraded so rapidly in cells that it wouldn't be able to translate into protein and stimulate the immune response. So yeah, the RNA is just very rapidly, it's a fact of molecular biology. It's degraded very rapidly and it can't integrate.
So here's a question on vaccine adverse effects. Given about 350 million people in the US, if 1 in 1 million vaccinated have an adverse effect, you know, for instance, get COVID, yes, then 350,000 people will get COVID if everyone in the US is vaccinated. If the death rate is 0.28% from COVID, then about 980 people in the US will die from the vaccine. Is that correct? What would media and CDC response be? Are they looking at being proactive about that response?
Yeah. Well, I lost the math there a little bit. So if it's 1 in a million,
Right,
and
so
we
350,000.
350 million people in the US, there would be 350 serious adverse events. Does that sound right? One per million, 350.
Right, you're right there. Yeah.
So now the worst case scenario is death, but I'm thinking that's very unusual. So in the worst case scenario, we have 350 serious adverse or severe or serious adverse events,
And
which
fewer
could
than
be
that would die. Yeah, I think I think it was a confusion of 1% versus 1 in a million in that.
right. It's 1 in a million and again, with all the vaccines that have ever been produced, they're all in that range of 1, maybe 2 in a million or less. So yeah, in my simple math, if that means if we have 350 million people receiving the vaccine, we would get 350 total serious and or severe adverse events, which is certainly a lot fewer than the number of people that have died, already of COVID. So yeah, and that gets into the vaccine risk versus benefit. There actually may be certain age categories in the US that would be, but I think even in the best case scenario, even in like young people that have very rare severe outcomes, I still think vaccination would be even more, adverse event from vaccination would be even more rare.
So there are some general questions about the morality of the vaccine as well. One participant asks if we have Catholic scientists that are working specifically to produce morally acceptable vaccines. Is there any coordinated effort on that?
I heard that there's something called the John Paul II Institute, and I don't know anything about it, but yes, I heard that they're working on a vaccine. And maybe somebody knows more than I about that, but I've heard that. I will say the chances of overtaking the current, leaders would be very difficult. I mean, the sheer amount of money and resources needed to get FDA approval is enormous.
In your experience in virology and vaccine production, is there any benefit to waiting to receive a vaccine? That is, are vaccines ever improved after initial release?
Yeah, of course. Yeah. I mean, one would hope that, I mean, the story of polio is tragic. I mean, they had the two vaccines, I think it was the oral polio, which was alive attenuated. And then they had the other one that was killed, and they had problems with both. Like one, the killed vaccine wasn't killed enough, so people got polio. The formalin didn't inactivate it enough, and then the live attenuated caused polio in some people. So yeah, there are improvements that are made. However, the technology we have now is better. I really expect that there won't be. I think there's going to be fewer adverse events with these. Just RNA. To me, conceptually, RNA is a safer way to go than a complex virus that's replicating in you. So yeah, there's always a chance there could be improvements. I think the safety is probably not going to change. We may get a more efficacious vaccine, but I don't think we'll get anything much safer. But again, so far the data looks great, but once it gets into millions of people, we'll really know. What I'm concerned about is if you have one adverse event, people are going to get really upset. And I mean, if we had one, that would be almost miraculous, really, if you think about 1 in 200 or 350 million. But anyway, people's standards and ways of looking at things are very different now.
Are there any controversies projected for long-term effects of the vaccine? Have you heard any chat about that?
The news is always presenting kind of potentially, like, I think the biggest controversy I've heard is the duration of immunity, which is a question nobody knows when any vaccine is approved, because by the very nature of that question, you have to have time, 5, 10, 15 years. That's the only controversy I'm hearing, is that will these vaccines actually provide long-lasting immunity? and will we need to be revaccinated every year and so forth? I do not think we'll need to, I mean, this is not, we were talking about this before we came on. Influenza is a totally different scenario. It's a segmented virus. It actually has, I forget how many there are, 9 or 10 segments of RNA. And so they can reassort. And so basically every year we have totally new viruses we've never seen before. But this is not that kind of virus. This should be a very stable. So I would be very surprised if people were no longer immune after a year. It may be 10 or 15 years. That happens with other viruses as well.
And of the vaccine candidates that you're aware of or that we've discussed, are they all mRNA? A participant asked if AstraZeneca is actually working on a DNA vaccine.
No, AstraZeneca is not an RNA vaccine. AstraZeneca is a adenovirus vector. It's one of these chimeric viruses. They took a standard monkey adenovirus, which replicates in humans, and they added the coronavirus gene to it. And so, yeah, that's not an RNA virus.
Okay. Do you foresee the potential for different issues with that, or is it too soon to tell?
Well, the adenovirus vector approach is also brand new. There's never been a vaccine approved that uses that approach. It's an approach that's been looked at for a long time. In fact, when I was at CDC, we were taking yellow fever vaccine, the 17D vaccine, and we were putting things into it like West Nile and Zika and others. Same exact principle. We just swap out one portion. So we know yellow fever vaccine works well in people. It's been around. So I think it's the oldest vaccine we know of for a virus. We know it's safe, relatively, 1 in a million. And so we were inserting genes into that. But that approach has been thought about and looked at, but FDA has never, approved it before. So we'll see.
Another participant asks if we are aware of any possible effects on the reproductive system from these vaccines.
Not any more than we would from any vaccine. I mean, there shouldn't be any difference in what we've seen in the past. And I actually don't know much about, have there been reproductive problems, from people receiving these vaccines? I have no idea.
Okay. And a couple of questions about potential moral issues again. One participant says, to be clear, both of the mRNA vaccines are acceptable for use by the Catholic Church. And I would assume we're talking about the Pfizer and the Moderna there.
Yes.
And another person asked specifically if there would be a foreseeable dilemma looking at vaccine distribution. If, for instance, in Northern Colorado, the AstraZeneca vaccine was released while in Denver or, another state, the Moderna is available. As Catholics, do we have the moral obligation then to travel to try to receive the more morally acceptable vaccine?
I would say yes. I would say that's what the church, I mean, I don't think driving to Denver is a big problem, or driving from Denver to Fort Collins is a problem. If it meant that if the only possibility of getting the morally acceptable vaccine was doing something heroic, like driving to San Francisco, I think the church would say that that's, a bit much. I mean, in the end, people have to make a decision about what they're willing to do. But certainly if I was presented with that choice, I would drive to Denver. To me, the RNA vaccines are the morally acceptable choice because, again, they're not produced using any cells. Again, there is this controversy. There's a bishop in the US that says, well, even though the National Catholic Center for Bioethics and others are saying it's morally acceptable, he has said, I'm saying it's not, so that's a whole nother chapter that I think is, but anyway, between the RNA vaccines and a vaccine grown directly and produced from cells from an abortion, I would always choose the RNA vaccine within reason. And it looks like we're not going to even have to make the choice because Moderna and Pfizer are both within days of getting EUA approval. And my understanding is both of them will be available here.
So again, it may be moot, as you're saying. An issue, I guess, that I would contemplate is that it's not going to be all of a sudden a sign at Walgreens saying, come get your
Right.
vaccine. There are very specific, because the supply is going to be limited for some time, because the need for 350 million, well, it's 2-dose series, I believe, on some of the vaccines.
All of them
So,
are 2-dose.
so if you say you need 600 million doses, it's going to take some time to be able to produce that. So I don't know how many people have seen the priority lists that the CDC and the Colorado Department of Public Health are publishing.
Yeah, I wonder that myself. I know nothing about how they're prioritizing. I think because another advantage of the RNA vaccines is they can be produced in huge amounts. And I think they are, because it doesn't involve growth of any kind of virus. This is a reaction that can be mass produced. So yeah, I don't know much about their production capabilities. The only thing I know is the whole shipment issue. There's a difference between the two RNA vaccines in terms of storage, and Pfizer's come up with some elaborate way to ship on dry ice and to keep it frozen at -80 for so many days, and then they have to use it. So it may be that Moderna will, but I think they're both already shipping even in advance of the EUA approval.
That's the rumor. Let's see. A participant asks, there's a few things. There's a question if we know what cells are targeted by the mRNA viruses in the human body, and if they affect all cells or just certain cells.
Oh, that's a great question. I'm sure that they know that. I don't know what the target cell is. I don't think, so, every virus does have a target cell. I mean, they have what we call tropisms, and it's based on their receptor and all that kind of stuff. This is a lipid nanoparticle. My understanding is it generically will sort of insert itself into a host cell through that lipid bilayer membrane. I don't think it has a specificity. So starting with cells at the injection site, I mean, to stimulate the immune response, what's needed is that the cells adjacent to lymph nodes get infected, and that just generates the whole cascade of the cellular and humoral response. So I think when you vaccinate IM, that's what's going to happen. I think, but many cells in that area without any kind of selection should be not infected, but the RNA should get into those.
There is a question about your own personal thoughts with your experience and background. What are your personal feelings or thoughts on the vaccine being available already? When these become available to the general public, would you personally get the vaccine? Would you recommend it to others?
Personally, if I could be first in line, I would. And the reason is, I just know, to me, I think RNA is inherently safe. Now, I'm wrong about stuff, but I spent a lot of time working with RNA. Everything tells me that in theory and conceptually, it should be very, very safe, and it seems to be working. So my personal choice will be to get that vaccine as soon as I can. Either one, I don't care, of the RNA vaccines.
Here's a question about participant says, I had read a story about the flu vaccine. Someone was working on a universal flu vaccine that was aimed at the stick part of the spike protein instead of the end. It was my understanding that the end of the spike protein is the part that mutates or changes, but the stick part is the same. So this would mean this type of vaccine would be against any flu virus. Do you have any thoughts on that or information on that?
I don't know. I don't. I mean, flu doesn't really have a single spike protein. It has what's called the HA, the hemagglutination protein, and it's associated with another protein, and those two in conjunction are what facilitate flu entry into cells. And I think flu uses sialic acid containing cellular proteins. So I don't know much about that research. I mean, yeah, I don't know. It has nothing. It's quite different than coronavirus.
Okay. There's a comment here about the HEC293 cells that are also used for the CAR T cell therapy. And just saying, we still need to keep looking for better solutions on that.
Absolutely. Yeah.
So, uh, participant is thanks you greatly for your expertise, insight, and doing a great presentation.
I hope I didn't bore anybody with the,
Personally, I will say it's just trying to retrieve those parts of my brain that can work with immunology at all and process the information. There's also a comment here. They're already asking staff to sign up for vaccines in a few Denver area nursing homes, looking at a staggered approach to avoid everyone getting possible adverse reactions at once.
yeah.
So it I don't know if you've seen any data, for instance, just, talking about newer vaccines, the Shingrix vaccine is notorious for producing a fairly brisk immune response in people, which is probably why it's got such a high efficacy rating. Have you heard anything about these vaccines and whether they're getting similar reactions?
I, I don't know much. So this is the zoster vaccine, right?
The varicella, the Shingrix, yeah, the
Yeah.
zoster.
I don't know much about that vaccine. And so to compare it back to Corona, I don't, I mean, the basic thing they look at is, again, are you making antibody? Are your T cells activated? And are you protected? And that's what FDA is looking at. And is it safe? What's the frequency of adverse events? And on all counts in these phase 3 studies with about 30 to 50,000 people, they seem to be looking really good. You'll never know until it gets into millions though, right? I mean, that's always but I think we have a pretty good idea.
Okay. And let me just scroll through and see if I've missed anything. Um, I believe you said that this is not the case yet, but there is a question about whether there are any current vaccines using the mRNA technology.
No, Moderna started their company on this principle. They have vaccines for Zika, for West Nile, for Ebola, for all kinds of stuff. But it's so difficult to get vaccines approved that it's sad to say they needed an event like this to get their technology. And actually, this could represent sort of a quantum shift in vaccine production because, again, people just do things the same way over and over again. Killed vaccines, attenuated vaccines. If the Moderna vaccine turns out, or Pfizer, they're both the same. If those vaccines turn out to be very good immunogens, they stimulate the immune response and they're safe. My prediction is we'll actually see all of the other ones go that way. We'll see a rubella, a mumps, a measles. They'll go to that technology if it's better.
Okay. We have had a question about availability of information afterwards. So to our participants, we will be sending out some follow-up information with references to some sources of information about Catholic teaching on the vaccines, summaries
Yes.
of some of the status of some of the vaccines on trials. And we are trying to make a recorded version of this available as well. So within the next day or two, watch for that information in your inboxes. I think that brings us to the end of our list. I want to apologize to anybody still on the line if I missed any questions. If I did, please go ahead and send an email through the our CMA email, and we will try to get back to that. So Deacon Rob, thank you so much. Great information, and we will continue to pray for healthy outcomes and a quick availability of this. I've personally warned people that it's not a magic wand, and just because we begin vaccine, we're not going to instantly see a change in the tide. But I'm hopeful
Yeah.
that this will bring us to a faster, safer conclusion.
Right. I mean, that gets into the concept of herd immunity. I mean, to get to a point of 70 or 80% of the population immune is going to take a while.
On a closing note, um, immunity in the community, independent of the vaccine, is still a huge question. Any thoughts on that? I don't know if now that you're not directly in the field, if you've seen any data
Yeah.
that's
So I'm following this as they've done sero surveys, which is really the only way you can look back and say how many people in a certain region were exposed or infected. My recollection is New York is the exception. New York is, I've seen numbers 10, I've seen 15%, 20%. So very high. And there's a study that CDC did in 10 other regions, some fairly large cities. There's nothing above 5%. I think it's mostly 5% or less. So still relatively rare for people to get infected, even though there's a lot going on. In the big scheme of things, other than New York, there's still, 95% of the people have been not exposed. So that is why vaccination, to achieve a level of immunity where we start to see the disease go away, most people think somewhere at least 70% of the population or greater. So we're going to have to rely on vaccination. I don't think natural infection is going to get us there. We don't want that route anyway.
Right. I've seen a lot of debate about this. I haven't followed it as closely recently. There was, at least in pre-publication form, a study out of based on data from one county in California, I believe, where they had better data, much larger sampling, I believe, of serological results. And then they were doing a statistical extrapolation. And it was the basis for some of the arguments that that COVID is not as dangerous an illness. I don't know if you saw any of those studies or reports.
I'm not sure which. I mean, like I said, there was a CDC study of 10 different regions around the country, serological surveys. So, I mean, I think what you're referring to is what everybody wants to know is the infection fatality rate, right? Like if you get infected, what's the chance of you dying from this? That's a very difficult. We do know the numerator, right? We know how many people are dying from this. The big question mark is how many people were actually infected. We can't go by cases. Those are the people that were symptomatic. So the only way you can estimate the denominator, which is the number of infected people, is to do a sero survey. And so that's probably what they were saying is if you do that math, and that's where the CDC came up with, I think the current, well, there's all this confusion about case fatality rate versus infection fatality rate. Case fatality rate's always going to be higher because you're just looking at people that have symptomatic COVID. But infection fatality rates, I think, are going to be about twice of flu, 0.2 or something like that. So anyway, I mean, that may be what they're.
Yeah, it is the ongoing arguments about the denominator. I don't believe this was a CDC based study. And again, the data that I saw was in pre-publication, so not reviewed yet.
Right.
But I think it is the source of some debates that actually get quite heated at the moment.
Of course, yeah, that's been the debate from the beginning is, how dangerous is this? And I mean, in terms of the perspective of looking at other viral infections and other outcomes and all that, it's probably not as serious as they made it out to be at first. They were talking about infection fatality rates of 5%, or something like that early on. That's frightening, And so compared to that prospect, I think 0.2% is a much better scenario. But anybody who dies from this is a tragedy. We don't want anyone to die, but So just looking at numbers sometimes doesn't always.
No. Well, as a clinician, the perspective, trying to give people is the problem is we're starting with 330 to 350 million naive people in this country alone.
Right.
And so it does not take a large percentage to result in a large number of real people.
Right. What's point? I can't do it in my head, but what is 0.2% of 350 million people? That's a lot of people.
Yeah.
I mean, it's so.
So 3 million, 300,000, 600,000.
I'm doing the math right. I have my calculator here.
I took the 50 out. It confused me too much.
I have 700,000.
Yeah.
That's a lot of people. So.
Right. So, and in terms of crippling the economy, and you can't afford to have 20% of your police force, 20% of your hospital workers, 20% of anything out all at once.
Right. Right.
So, all right. Well, I don't see any more questions in the chat room, so I will wrap it up at this point. Again, thank you greatly. And we will look to do some follow-up in the near future.
Okay. Thank you.
Thanks, Deacon.